Mr. M is a 65-year-old male who is generally in good health, who presents to the clinic today following increasing shortness of breath over the last 2 weeks. Mr. M had been feeling well until approximately 2 weeks ago when he started feeling an increased shortness of breath with activities he typically has no problems completing. When he first noticed it, Mr. M found he was feeling more winded than usual with his weekly basketball game with friends. He then started noticing the shortness of breath progressing and showing up following more simple tasks. Eventually, he found himself being short of breath just walking up the steps to bed, which is what clued him into seeking medical care today. He feels weak and lightheaded alongside his shortness of breath. He notices his shortness of breath, lightheadedness, and weakness any point throughout the day following mild exertion, but this relieves itself following a few minutes of rest. Along with his shortness of breath, he notices that his heart flutters when he exerts himself, but it goes away quickly upon resting. He also complains of being lightheaded when he stands or overly exerts himself, but that too goes away with rest. He feels fatigued and weak no matter how much sleep he gets. He says he felt cold recently, despite wearing more clothes around his house. He has noticed darkened stools that started approximately 3 weeks ago. He's had gastroesophageal reflux disease for approximately 20 years now, which still acts up depending on what he eats. He says his father has had stomach bleeds before. He's had pain in his right knee since he fell at work approximately 1.5 months ago. He's been taking ibuprofen regularly to help manage this pain. His right knee has caused a moderate amount of pain and says he can't bend it the way he used to before the fall. Although he has shortness of breath with exertion, he has no shortness of breath at rest. He has no cough, wheeze, congestion, sneezing, or runny nose. There's no family history of lung cancer and no personal history of lung disease. Along with his shortness of breath and heart flutter, his lightheadedness goes away with rest. He has no orthopnea or shortness of breath at night. He has no headaches and no night sweats. He denies any chest pain, shoulder pain, or pain anywhere besides his right knee. He has no weight loss or change in appetite. He denies any nausea or vomiting. Despite his darkened stools, he has no diarrhea or abdominal pain. This is the first time Mr. M has sought out care for this specific problem, and he states he has never felt like this before. Mr. M states he has been on pantoprazole 40 milligrams daily for approximately 20 years now. He also notes taking ibuprofen regularly over the last month and a half following his fall at work. He admits to taking 4 or 5 600 milligram tablets per day, depending on his pain level. Mr. M has been told he has osteoarthritis in his knees, but hasn't needed any medications or procedures before this fall. He also notes a diagnosis of gastroesophageal reflux disease for 20 years, which is moderately controlled by his daily pantoprazole. The patient lives at home with his wife and 2 children. He still works regularly, and he hasn't traveled anywhere outside the country for many years. He doesn't smoke, but he does admit to having a few drinks a couple times a week. The patient has slight orthostatic hypotension upon standing, with his systolic blood pressure dropping 15 points to 93/58. This orthostatic hypotension coincides with his dizziness. His heart rate was slightly tachycardic at 110 beats per minute while marching in place. His oxygen saturation remained relatively stable at 95% on room air while marching, although his respiration rate increased to 24 breaths per minute. He doesn't have a fever. He appears pale in his face and conjunctiva, with dark rings under his eyes. Besides these symptoms, he appears to be in generally good health. There is no audible wheezing, stridor, or cough noted. He has normal breath sounds throughout his lungs, with a normal rate and rhythm at rest. There's no obvious signs of cyanosis. His anterior-posterior to lateral chest diameter is approximately 2:1, and there's no accessory respiratory muscle use detected. His radial pulse measures 1+ and feels weak and thready bilaterally, with a normal rate and rhythm at rest. No edema is noted. His jugular venous pressure measurement is approximately 2 centimeters. Mr. M's abdomen is soft, non-tender, with normal bowel sounds oscillated in all 4 quadrants. No ascites is noted. The patient's right knee is slightly swollen, being larger than his left. He has slight crepitus and decreased range of motion felt, but no gross abnormality is detected. His hemoglobin is low, at 8.5 grams per deciliter. His hematocrit is 27%. He has microcytic and hypochromic red blood cells, and his red blood cell distribution width is elevated. His creatinine is higher than usual at 1.1 milligrams per deciliter. His electrolytes were normal, within normal range. To summarize, Mr. M is a 65-year-old male who presents with increasing shortness of breath over the last 2 weeks. He has a history of moderate drinking, and he has been taking an excessive amount of ibuprofen for his knee pain. He now notes dark stools. He's pale, with a blood pressure lower than usual and a heart rate higher than usual. He has a weak and thready pulse. He's also lightheaded when standing. He has general fatigue and weakness despite sleeping well. His lab work is indicative of iron deficiency anemia, possibly due to the blood loss, with low hemoglobin, microcytic and hypochromic red blood cells, and a low hematocrit. He has no chest pain, no cough, no abdominal pain, or masses. At this point, my top differential diagnosis for Mr. M is a GI bleed secondary to excessive intake of ibuprofen. Risk factors for a GI bleed include his history of ibuprofen intake, his GERD, and his moderate drinking. His progressive shortness of breath and his lab works indicating iron deficiency anemia, along with his darkened stools, are possible evidence of this GI bleed. Another possible potential diagnosis is a pulmonary embolism, but this is less likely due to the progressive nature of his symptoms and the lack of risk factors for blood clots. Pneumonia is even less likely due to cough or sputum and normal breath sounds heard throughout his lung and no fever. Thank you for your time.